Thank you very much for the introduction and the opportunity to speak. As listening to the fascinating discussion, I was contemplating switching my talk on the last minute and giving you what I gave at the AHA last year about using biomarkers as surrogate endpoints and on the pitfalls, all the pitfalls associated. But I think this one will be very relevant as well. And a little bit, everybody thinks precision medicine and has a different association connotation in their head. So I've spent my life building and evaluating prognostic models. So to me, precision medicine is really about prognostic and predictive models. And we can throw genetic information, we can throw in biomarker, we can throw in anything you want, but it is really stratifying people based on risk and then also benefit. That would be one of the claims that I will make. And it's important to remember that it may not be only this single biomarker or a combination of them or this genetic signature, but there is a lot of information that we already have that is very important. And we'll touch on that as we go along. Disclosures and the outline. So what I will do, I will talk about building these prognostic models and give through some statistical theory and important considerations and point out that there are a lot of decisions at every step that are not obvious, that are challenging and somewhat controversial. And then I will give an example throughout using the new pooled cohorts equations. That's the risk prediction model that was developed in 2013 and then implemented in the AHA-ACC guidelines for lipids to help reduce the risk of cardiovascular disease. And then as I'm going through the statistical and other detail of building the model, it hopefully will become obvious that all these decisions that might seem, oh, this is just a statistical thing, have profound influence on what the guidelines do and don't do. And then I'll illustrate that and go into the controversy. So this is hopefully an example, and I'll finalize with some caveats, but hopefully this is an example of showing how precision medicine has been applied in one particular context, which affects probably the most people that we can talk about, because statins are recommended for about half of the U.S. population, age 40 to 75. So we're talking about large impact. So I'll start with the example, the pooled cohorts equations. So the effort was the risk prediction models in cardiovascular have been developed in the Framingham Heart Study for generations starting in the 1970s and then making it into literature in the 90s and become more and more popular. The ATP3, the previous lipid guidelines, used the function developed in Framingham. Now they said, well, we have more studies in Framingham. Let's pool them all together and develop a function that uses the studies that the NHLBI has been funded over the years. So we have Framingham. And they used two cohorts, the original cohort and the offspring cohort. Participants aged 20 to 85 were available in the 1970s. Then the ARIC cohort, where we have people 45 to 65 at baseline. The cardiovascular health study, which is 65 and older, and Cardia, the youngest participants at enrollment. So as we try to develop a prognostic model, a risk prediction model, we have to define the population of interest. And this is, again, I guess, violated more often than you think. Having worked in Framingham, you see the Framingham functions develop all over the place for all sorts of things. And I had numerous discussions with investigators who just like to take Framingham, apply it in secondary prevention, and say, well, this is my Stroman, I'm going to do better. Well, it's not a good Stroman because it was never developed for secondary prevention unless you use one of the very specific Framingham functions that hasn't gotten that much attention. The general functions are for primary prevention. That's the use, and that's where they are supposed to be meaningful. If you use them in secondary prevention, they will be miscalibrated. We don't know if the effect of the variables will be correct. So it's definitely an off-label use at the very least for the function. And of course, if you test your biomarker, and ask a question, does it add value beyond Framingham? In a setting that Framingham is not supposed to be applied, you're going to see a much better performance than you would otherwise if you conducted the principled experiments and applied Framingham as it should be. So the population of interest is key. Then you get into discussions, okay, what's the age range for people for whom we want the risk prediction function? On whom are we going to talk about statins and so on? And the decision was made 40 to 75 with the guidelines, and the function was 40 to 79 because they said, well, the 75 to 79, we don't quite know what to do. We want the function still to be predicting. And that was interesting because the previous function started at age 30. So we have a decade of people eliminated from the function, but for a good reason. Because looking at 10-year cardiovascular risk in people in their 30s is likely quite misleading because the risk appears small, even though the risk factor burdens might be high. Then who are we excluding? Right? If we want to look for onset of new cardiovascular disease events, it makes sense to exclude people who already have cardiovascular disease. So is it primary prevention, secondary prevention, and so on? And then how do we define it? Then probably the most important question and discussion that led to huge amount of controversy after the guidelines came out was, what do we do with people who are already on statins? And there was a clear choice between the authors of the function. And it was the choice between using contemporary data versus the least confounded data. So they could have either used data from, say, the 90s, that's where we have the cohorts, right? You have baseline in the 90s, so you go for 10 years, so it's contemporary, where statins were increasing in use. And again, this is to be used for a guideline to determine if people should get statins or not. So we can take the contemporary. There is statin use confounding the associations. The data is more contemporary. The other option is use older data from the 70s and 80s, pre-statin use, where it's not confounded by the statin use, right? So again, if we're asking a question, should this person get a statin, we want to know what's going to happen to that person if they don't get a statin. Would be great to know what's going to happen to them if they do, but that's more clinical trial than observational data cannot give you that information quite reliably. And the decision was made by the authors of these functions to go with the older cohort, right, to avoid confounding, pay the price of the contemporary data, but then that created issues related to the calibration, to the what's the value of predicted risk. But this is an important discussion, and I'm not sure that there is necessarily an easy answer one way or the other. Then the definition of outcome, and as you look at the history of cardiovascular risk prediction models, the outcome kept evolving. So the Framingham function, I think that with most citations, is the one published by Peter Wilson in Circulation in 1998, where they took coronary heart disease as the primary outcome, and here's the definition. Then ATP3, the previous lipid guidelines, looked at hard coronary heart disease, just limiting it to MI and coronary death. Then Framingham published another paper looking at full CVD, broad spectrum of cardiovascular events. And then in 2013, they said heart CVD is that what we want to use, as it aligns maybe best with what's currently done in clinical trials. So you see the definition keeps changing, and this will have implications on which events are included, what is the event rate, and so on. And the question we need to answer is, what do clinicians, patients really care about? Why are we giving statins? What are we trying to help? And which events we'd like to eradicate? Then there is the issue of the duration of follow-up. The functions historically have been used with a 10-year horizon, and that was kind of, well, 10 years seems good. You want to avoid disease in the next 10 years. But then the issue becomes, when you look at the younger people, and especially women, 10 years, the risk in 30-year-olds is so small that it gives you the impression that nothing is going on. So 10-year horizon might be misleading. Maybe we should use longer horizon, maybe lifetime risk, maybe 30-year risk. So as we develop these models, the other big consideration is which mathematical model to use, and then everybody in cardiovascular field likes Cox regression because regressions are simple to understand and interpret, and we all know them, and reviewers know them, so on. Now machine learning is entering the field, and so far it needs to prove itself that it will perform well enough in validation setting, and some of these techniques, more modern techniques, start appearing more promising. Then there is the issue of competing risk and multi-category outcomes, especially where the duration of follow-up is long. And the main setting is if treatment is suspected to have beneficial effect on one set of outcomes, cardiovascular disease, but increases other outcomes, say increased risk of diabetes using statins, and then ischemia versus bleeding in other classes of drugs, and we could multiply the examples. Interestingly, the impact increases with the decreasing number of non-events. So the more events you have of all types, the bigger issue. This is primarily absolute risks are affected, but can also, under some dependence patterns, affect relative risks, right? So you could say that the best therapy for cardiovascular disease is to smoke a lot, because you will die of cancer before you have a chance to develop cardiovascular disease. And if you don't model appropriately, you might get issues like that with competing risk, where smoking would actually look protective. Then as we put these regressions, we need to use a form of predictors, and people like to dichotomize predictors. Like I review a fair amount of biomarker papers and added value of biomarkers to prognostic models. And what happens, people like to dichotomize the standard predictors that they have to put in the model, and then put the biomarker as a continuous predictor, this shining knight coming in. Of course, looks better because you've done either knowingly or unknowingly things to the other predictor. So there are issues around that. And then there's the log transformation of biomarkers, and they're often log transformed because people believe you need to normalize your predictors in the prognostic model, which you don't. So a lot of technical details. And what's important, again, is standard risk factors, and those that we know we can influence should enter the model before the novel things enter in, right? So there are a lot of companies talking about precision medicine springing up, especially on the West Coast, that they offer to genotype you and give you your cardiovascular risk based on the genetic information. And there is very little in terms of scientific literature to support the value of that, but it's I guess it's a lucrative business. So my take is, when you develop a cardiovascular disease model, include the variables that we know are related, and that if we modify their values, we're going actually to affect the disease itself. So systolic blood pressure with its treatment, total HDL cholesterol or some lipid variables, diabetes or form of blood glucose, and smoking should be in before we put anything else. And there are questions, should the models be sex-specific or pooled? Should age be a risk factor or a scale of measurement? And again, with appropriate tools, this can be sorted out. And then the issue of absolute versus relative risk as it pertains to the use of these models, but also patient communication, right? It makes a big difference for a risk to increase from 1 to 2% versus 10 to 20, even though relative increase is identical. If you tell a patient that their risk of cardiovascular disease in the next 10 years is 10%, that will not mean much to them. The immediate question would be, how does it compare to somebody else? So they will want some context, and they would probably will go into relative terms one way or the other. I think both are useful, but it's important to keep in mind the distinction. And then performance of the models, discrimination coming from diagnostic assessment is the ability to distinguish those who will have events versus will not have the events. And in longer-term survival, if most of people have the event, you might want to distinguish between those who have events earlier versus those who have events later. And you can examine histograms of risk distribution. The area under the ROC curve, called the AUC, is commonly used in binary classification with extensions to time to event outcomes. Here is an interesting example showing two discrimination metrics, the AUC and what we call discrimination slope, which is the difference in means between risks among events and non-events. And what you see here, using a Framingham model, when you put age only in the model, the AUC jumps from 0.5, which is a random model, to 0.74, right? So huge gain with age alone. If you put risk factors only, so lipids, blood pressure, diabetes, smoking, you get 0.77 without age. And if you add risk factors on top of age, you go only from 0.74 to 0.80. So interestingly, age gets you from 0.5 to 0.74, and everything else only from 0.74 to 0.80. Well, this is a little bit of a biased assessment, but that's what's being currently used and viewed. The reason you gain so much in age, well, age is important. If you're trying to distinguish the probability of event between a 40-year-old, cardiovascular disease event, 40-year-old between 70-year-old, well, it's pretty obvious, right? So you're getting a lot of points in terms of the discrimination performance for the model being able to make this simple distinction. The question would become much more interesting, and I think personally that's where the future of prognostic biomarkers in cardiovascular might be, if you conditioned on age, and that's what they do in cancer oftentimes, and said, among 50-year-olds, how well can I differentiate those with events without, between those with and without events? And then things that we're throwing out might all of a sudden start showing value. The question is then clinically and for applications, do you really want to make a distinction within 50-year-olds or every age group in terms of their risk, or are you just happy saying, well, 70-year-olds have higher risk, so let's treat 70-year-olds? So it has to, the type of the model you're constructing has to be related to the clinical or policy application for which you will be using the model. And then the elephant in the room is calibration, and it has gotten a lot of attention after the pooled cohorts equations came out in 2013 with Paul Whitaker and others sounding alarm of calibration being an issue with the new functions. Actually, calibration is not a single definition concept. There are levels of calibration. The simplest are the means of the predicted risks equal to the incidence rate overall. Then you can talk about weak calibration, moderate calibration, and strong calibration, and maybe best to illustrate it with graphs. So plot A shows you a situation of a model that's strongly calibrated. So if you look at the observed risks and the predictions, they align perfectly. Then you have the moderate or calibration, the weak sense, it's plot B, where you're not aligning perfectly, but in general you follow the linear pattern. So there might be some bumps around, but the pattern is followed. And in plot C, you have the calibration is off, right? There are three groups, and strange things are happening. But back to the definition of the endpoint, depending how you define the endpoint, we take full cardiovascular disease versus hard coronary heart disease, the event rate will double with one function versus the other. So if you keep the threshold the same, but your event can go up by a factor of 2, obviously the numbers of people that would be considered as candidates for treatment will move vastly up or down depending what's happening. It's also depending how long the time horizon is of your follow-up and so on. And then also the question, well, is there such a thing as overall US calibration? Should the function be calibrated to the entire country, or should it be state or region specific? In Europe, what they are doing, they no longer have an overall European function. They're calibrating every function to every country, right? So there isn't a European function. It's country-specific functions that they're looking at. And then there are cost considerations related to the choice of thresholds. So if we take a risk prediction model and say, okay, a person with risk in 10 years over 7.5% is a candidate to receive statins, this choice of a threshold has cost implications whether we like it or not. So following the premise of decision theory, if we called C10, the cost of classifying event as low risk, and CO1, cost of classifying non-event as high risk. Right, so the first one is not giving a statin to somebody who will have the event, and the other cost is giving a statin to somebody who wouldn't have the event. The classification threshold over 1 minus the threshold is equal to the ratio of these two costs. Okay, so if you're saying 7.5 as your classification threshold, then roughly speaking, it would be what 1 to 12, 1 to 13 of giving a statin to somebody who doesn't need it versus not giving a statin to somebody who will need it. That's arbitrary, and we may or may not agree with it, and these costs can be person-specific. But going with a fixed cost like the guidelines did, and assuming rational decision-making by the patients and providers, this would be the implication. And then we want to transport and validate the function and internally and externally to make sure it works. So now to the application with the guidelines. So the AHA-ACC guideline defines 4 statin benefit groups, and the main changes to the previous guideline include treatment is based on cardiovascular disease risk rather than cholesterol level. That was a huge change, a lot of controversy, and a lot of discussions are ongoing. It is, I guess, in the direction of precision medicine, understood as more use of prognostic models. The threshold was chosen at 7.5 risk without necessarily a health economic justification going with it, and then no lipid levels to modulate the recommendation. And reducing LDL levels needed to initiate treatment in secondary prevention persons with diabetes. So basically, they went down from 100 to 70 as the level where people should get statins. And the new function was used, the pooled cohorts equation, and interestingly, stroke was added to cardiovascular death and MI as a component, which again will have impact on the importance of age in the function. So the implicit assumptions were that statins work across all levels of cholesterol. That's very important, right? It will reduce risk no matter what the cholesterol level. The main goal is to reduce risk of future events. The statins are used to treat risk and not lipid levels, which is very interesting. Stark to recent blood pressure guidelines, which are all about treating your blood pressure level, not about not risk directly. Age is a key factor as a main driver of risk. And even in the document, they say it quantifies the cumulative exposure to risk factors, so they acknowledge that. And they say it's not a comprehensive guide to lipid management, therefore treatment of blood cholesterol to reduce risk of cardiovascular disease. So we looked at it in some detail and looked at the implications of the guidelines using the enhanced sample, extrapolated 115 million US adults in the 40 to 75 years of age and analyzed the survey according to the principles. So here are the requirements for statin recommendations using the 2 sets of guidelines. So people in secondary prevention with CVD, we see the lipid levels eliminated. Then high LDL didn't change. The diabetes lipid is reduced. And then we have a more complex interplay between risk and lipids in ATP3. And the new guideline just talks about the risk. And the implications are as follows. In secondary prevention, so people with cardiovascular disease, 5.8 million already on therapy, and statin recommendations goes up by 2.4 million. That's eliminating the LDL level requirement. And then in primary prevention, 19.4 million already on therapy, which is about 20%. And then statin recommendation, high LDL doesn't change. Then in diabetes, the lower LDL threshold increases the number, and then the biggest change due to the change in the risk model. But digging deeper, we looked at the changes based on age of the individuals, and what we found was quite striking. So in the 40 to 59 years of age, the new guidelines don't differ from the previous ones very much. The bars are pretty much identical, And based on risk, we have more people with diabetes, but actually fewer people with increased risk, which is very interesting and counterintuitive because the levels of risk or threshold went down from 20% with ATP3 down to 7.5% only. So you would think it would be so much easier to treat. Now the endpoint change and the function is different. And then the entirety of the difference is pretty much in people 60 to 75 years of age, where the percentage recommended goes from a little over 50 to almost 80%. So then 49% of the 115 million would be recommended, increase from 38 with the previous guidelines, 12.8 million potential new users of statins. Among older men, we go up from 30 to 87%, and older women 21 to 54, and in younger adults are hardly affected. So in terms of what the guidelines would do, they would lead to increased sensitivity. 17% of people likely to develop cardiovascular disease in the next 10 years could be treated, but decreased specificity. 9% of more people not likely to develop CVD in the next 10 years would be treated. So percentage-wise, the gain is higher, but obviously the pool of people is bigger on the specificity level. So we would prevent almost 500,000 first occurrences of heart attacks and strokes over the next 10 years, but we would be treating over 10 million more people who may not need it. So what's the impact of the risk model? We compare the percentages of individuals recommended using the new calculator versus the previous Framingham calculator. Overall, 24% with the new model versus 20% with the old, not a big difference, but then much more by age, 9 versus 13%, so actually we go down with the younger people, but among older adults, 66% versus 39%. So a lot of what we see is driven by the new predictive model that was used in the new guidelines. So is it safe to delay treatment until age 60? So what happened? Well, they added stroke to the new model. They used different cohorts. The age shifted. And basically the function, I showed you how Framingham function is already highly dependent on age. The new function likely is even more dependent on age, getting to a point that if you're a man in your 60s, if you have all perfect risk factor profile, you're still a candidate for statins because you're a man in your 60s. Okay, whether it's correct or not, again, we can discuss that. It's an issue that people are debating. Is high age is leading to higher risk, but then will using statins help? Big contrast between the lipid guidelines and the blood pressure guidelines, where they treat regardless of age based on blood pressure levels. Here, the treatment is based on risk and very heavily age dependent. Then we ask another question, well, are we missing something, basically not doing much to people in younger ages? And then another finding based on Framingham data, we looked at expanded exposure to elevated lipids, we call it hyperlipidemia, and defined it as non-HDL cholesterol above 160 milligrams per deciliter in between 35 and 55 years of age. So over 20 years, how many years you had your non-HDL cholesterol over 160? And we, for presentation, divided people into 3 groups. So those who had lipids below non-HDL below 160, those who had 11 to 20 years of hyperlipidemia, and those in the middle. And not surprisingly, those with the worst extended lipid profile had the worst risk factor profile of this group, and the risk looks higher. And then when we follow them for 15 years, clearly we see almost quadrupling of risk with people with prolonged elevation of lipids, 35 to 55, so they wouldn't be treated, they wouldn't be considered, we'll get to in a moment. So now what's important is, you would say, well, yeah, if you have elevated lipids, of course you're at a higher risk, but maybe you can capture it with the value at age 55. Well, even if you adjust for your value at age 55, you still have residual effect of carrying the lipid burden over previous 20 years. And that's also true in people whose CVD risk is below 7.5%, so below what the guidelines are recommending as treatment candidates. And interestingly, looking at 40 and 50-year-olds who would be recommended for treatment using the 7.5 threshold or even the lower 5% threshold, we see that the percentages among 40-year-olds are extremely small, and they're quite small among 50-year-olds as well. So the guidelines would be missing these people in large amounts who carry high burden of hyperlipidemia. Another question we asked is, well, we have just one threshold for everybody, and we have the younger people and the older people, and we're treating a lot of older people and maybe not enough younger people. What if we looked at age and sex specific thresholds, right? Letting the 7.5% vary across the age and sex ranges. And so we looked at that, looking at men and women and the different age groups. And what we see here, this is a simple plot of sensitivity versus 1 minus specificity in men. There is a huge variability of the impact of the guideline depending on where you put the threshold. So the 7.5 is the filled circle, right? So looking at the red line, younger men 40 to 55, we have about 80% specificity, about 30%, 35% sensitivity. If you go with the threshold all the way down to 3%, which is the open circle at the very end of the red graph, you get specificity only 30%, but you get 90% sensitivity. So huge implications of where you put the threshold on the numbers and percentages of people that you would be or would not be recommending for treatment. And a similar situation in women. When you look at those in older ages, the blue ones, what's happening is that the threshold is way too low, and actually raising the threshold, you would not be losing anything on sensitivity, but you'd be improving specificity for free. So again, another consideration of how the models are used relating to the threshold choice. So clear limitations of the fixed threshold approach. Improved risk prediction algorithms could be, well, the assessment and classification could be improved with age and sex specific thresholds. And you can actually, we were able to show that if you use that, the overall proportions, the profile would be better. You would gain sensitivity and gain specificity going into age and sex specific thresholds. But what this also points out to, this exercise, is as we're trying to develop biomarkers, it looks like in younger age groups, biomarkers that focus on sensitivity might be more important, because we do a pretty good job with the current approach of saying who doesn't need treatment, but we need to do better identifying younger people whose 10-year risk looks small, who are truly at a higher longer-term risk because of their risk factor profile. And the opposite in older age groups, where we're saying, okay, you're older, you need to get on treatment. If we found biomarkers in subclinical disease or different methods to identify people who don't need that treatment, so the focus on specificity in biomarker research could be helpful. So clear limitations of the 10-year risk horizon, maybe 30-year lifetime risk would be better, especially in the younger. And then there is the question of benefit, right? So the current guidelines say, well, we're treating risk. But the other big question is, who is going to benefit from statin treatment? Because if the benefit is, expected benefit is small or negligent, it's a different situation where the benefit is very high, especially in the younger, well, in all age groups. So an update, and I think they're thinking about updating the guidelines, moving more into the balance between risk and benefit seems essential in these discussions. And taking into account the exposure to risk factors is important, and then the competing risk of adverse effect of treatment needs to be better understood, right? If we put somebody on a statin for 20, 30 years, Are they going to be developing diabetes? What else is going to be happening? So in general, there are clear limitations of risk prediction models. There are many of them, and maybe there are too many of them. Done a review on risk prediction models in heart failure. There are like 16 different models floating around, and how would anybody know which one to use? You can flip it and try to use it to your advantage and say, well, maybe we should use all the models available to us and look at the distribution of risk and look at it as a measure of heterogeneity, right? If your patient gets a risk that's highly variable between the different models, it's a different story than having the risk very concentrated based on what you've gotten. If all 5 or 16 models are telling you the risk is 10%, it's quite clear that that might be a fairly accurate estimate. But if they are telling you it's anything between 2 and 30%, there is a lot of heterogeneity, so maybe you need to do more testing or look at other things. The other important thing is the risk that's estimated by the model is conditional on the variables included in the model. So we try to do confidence intervals around risk prediction models. They're clearly too short because they don't take into account all the variables that we have not measured. And they kind of give a sense of prognostic value of risk factors, but they don't give you the value of variable or the contribution to the burden of disease, right? The change in C statistic or all the prognostic things are not answering the question, if you eliminated elevated cholesterol, how much overall reduction you would have on the population level, and it's important to keep that distinction in mind. So in summary, you need to be careful constructing this model because the implications in their use are profound. Relation of interest, outcome, duration of follow-up are all important. Risk categorization bears a lot of unintended consequences. So even if you have a perfect model, how you categorize it will have consequences, either positive or negative. Meaningful guidelines should focus on both risk and benefit, and risk estimates need to be interpreted in the context of their variability. Thank you.